a larger family, at least we can counsel them better about how to do that. For instance, patients with low AMH should probably think about going directly to IVF, not just to get pregnant, but to establish frozen embryos for future pregnancy. So we find it to be an extremely helpful tool in our patients. Great. So without further ado, I'll just go on to introduce Dr. Roberts. So Dr. Roberts is one of the co-directors of PCRM. He is the facility director for our Victoria office, and I've known him a long time, for about 15 years. He's a graduate of UBC. He went on to do his residency at McGill University. He then went on to Cornell Weill Medical College in New York and obtained his fellowship in reproductive endocrinology and infertility. He was on staff at Brown University in Rhode Island, a prestigious university, for a few years before starting PCRM back in 2006. He's board certified by the Royal College of Physicians and Surgeons in Obstetrics and Gynecology. He's a vanguard leader in fertility preservation, and is going to talk to us today about a lot of the work that he's been doing with transgender fertility care. And I'd like to introduce Jeff.
Thanks, Ken. Perfect. We're good. Excellent. Hi, guys. Thanks again for joining us this year. Hope you're learning a lot so far. And I wanted to talk about quite an evolving area of what we do. If we can change the slides. Excellent. So I got to use the mouse.
This is where he knows.
Is it? Okay, perfect. We're good to go here. So yeah, very much an evolving area of what we do. It's going to be a lot of changes, and we're really just talking from a small amount of data so far and experience clinically. But I just want to touch on like with a lot of the reviews you'll see on this, the components of human identity and terminology, gender affirming therapies, and we're going to focus mostly on the hormone therapies and implications for fertility, of course. And the fertility preservation options and medical options really are no different than what we'd see for the cancer patients in our run-of-the-mill fertility patients. So I'd like to think I know a bit about the fertility aspects, but to this day I struggle with the terminology. And there's a lot of good reviews and resources out there to help us through it. But components of human identity is really gender identity in the brain, attraction, assigned sex, which we see in the labor and delivery suites, and gender expression. Is that good?
People just want your video on.
Well, they can't see the screen.
No, they can see. They just can't see you.
Oh, okay. People want to see me. So assigned sex is the classification as male, female, or intersex based on biological characteristics, typically in labor and delivery, of course. And this could include chromosomes, anatomy, of course, hormones, external genitalia, and reproductive organs. So there's female assigned at birth, FAAB, male assigned at birth, MAAB, and intersex, which would be where the patient falls outside of the conventional classification. Gender is where you bring in more social context, and that's being labeled as man or woman. Gender identity is the internal sense of gender, the way the person feels inside, or am I a man, woman, or both, or neither. Cisgender is when the identity matches the assigned sex at birth. Transgender has really become an umbrella, so it's not so much binary anymore, but it does describe individuals whose identity differs from the sex assignment at birth. And trans men, trans woman is a binary system. And that's for trans men, sex assigned as female or intersex, and then identifying as male internally. And trans woman is sex assigned as male or intersex at birth, and then feeling as a feminine as a female. And gender identity, you can also break down into binary and non-binary. Binary is yes or no. It's either I'm female or I'm male. And this can include cis and transgender. So transgender can be binary as well. Non-binary, the other term, gender queer, is more of a spectrum. So it's not just a masculine or feminine classification. There's a spectrum there. I personally have a bit of issue with the word queer, just using that word. I think gender diverse seems to be the better word in my opinion, or non-conforming individuals. And these are identities that are expressed in expressions that differ based on cultural and social context, based on assigned birth. Gender fluid is when there's somewhat of a change over time, so the individual can change, and there's movement between the degree of gender identity. Attraction is sexual orientation, and that's just the potential for emotional, intellectual, spiritual, intimate, and or sexual interest in other people. And this is, of course, often based on sex or gender. Heterosexual or straight is attraction to different sex. Gay, which can be female or male, label as attraction to the same sex. Lesbian is female identified, and that's attraction to the same sex or gender. And bisexual is both. Asexual is no interest, and pansexual is very diverse. So LGBTQ2S it's pretty much ingrained in our society as the label for the community. If you look at it based on our previous discussion, there has a mix of attraction and gender identity. So certainly individuals aren't going to necessarily identify with one category in there. So it doesn't really represent the community well, in my opinion, but it's the label that's given. And that's why you can see extending out each year. There's more letters that are added to account for people that don't fit there. Queer is, it seems to be a symbol that represents sort of the attitude, affirmation of diversity. Questioning is a process of reconciling feelings and what language to frame these feelings. So that's commonly used. Two spirits is an interesting term. It's an indigenous term, is actually first coined by Europeans that settled here to describe Native people who fulfill a traditional third gender ceremonial or social role. Obviously, these individuals are part of the community, but prior to imposing European values, they were very, very respected in the community and may have represented, in many cases, the medicine people, healers, and visionaries within, because they could understand both all aspects within the village, both masculine and feminine. Transition is the way in which individuals align themselves with elements of their social and identity and bodies with their gender identity. The word sex change really has been removed. I think that's pretty much been phased out. But it's important to note that not all transgender people suffer any level of gender dysphoria. It's thought to be around 20%. But transition can be a mix of all of these points here. Medicine hormonal would be the most common surgical. Social transition, changing of names, pronouns, and of course there can be legal transition. So really a growing area of medicine. This is, and a lot of data is collected from American surveys. The medical industry certainly interested in anything that generates more volume, and this is the plastic surgeons data looking at and projecting the amount of surgery that's going to be done in the coming years for gender reassignment. So it's really a growing area, and I think we all have to be prepared to address these issues and see these patients. So in Canada, it's about 1 to 3% of the Canadian population. And I saw one survey that's potentially about 10% of millennials have some level of gender nonconformity. And anyone with kids in school right now, I think that number is fairly accurate, just talking with my kids and their friends. About 50% of individuals that identify themselves as transgender actually go through hormone therapy, and about 25% would undergo surgery. But the same level have interest in parenthood, at least 50%. And despite the impact of these treatments on fertility, very few discuss this with their doctors. And actually about 50% report having to educate their physicians on transgender care, which is a little sad. And of those that potentially need fertility preservation, only about 9% of trans women and 3% of trans men actually pursue it. So there's two types of treatments. There's the hormonal treatments, and for the trans men, we're talking essentially testosterone. For the women, very much estrogen-based. And surgery from a fertility standpoint, most interested in, of course, removal of whether or not the gonad's going to be removed. So for the trans men, it's THBSO, and for the women, orchiectomy. And that's sterilizing, of course. So if you're going to do fertility preservation, it would have to be part of that. And that would be, it would have at least a year or two to do that. That's the minimum time they'd be on hormone treatment before undergoing surgery. So for the guys, the goal is masculinization, of course, and that's deepening of the voice, hair growth, building lean body mass, increasing libido. And this takes a bit shorter in the guys, 3 to 6 months of onset, and maximal effect after about 2 years. And none of them want periods. Don't know if anyone wants periods, but for sure these patients don't want periods, and amenorrhea is a huge, huge goal for them. Logically, you'd think giving testosterone would increase cardiovascular risks, but the cohort studies that are out there don't actually show any effect compared to cisgender female. Almost a theoretical risk of breast and endometrial cancer. So hysterectomy is still the recommendation, even though there's no data to suggest that. And erythropoiesis, polycythemia is not a risk per se, but just be prepared to see abnormal CBCs in these guys. Transgender TransCare BC has a great primer, and these slides come from there, and outline just the different protocols out there. But for the men, it's testosterone, and progestins is more to deal with the ones that don't become amenorrheic after testosterone. And this is just for your reference for the slides, just the general length of time it takes to affect change with therapy. So fertility risks, quite controversial. It doesn't seem to have nearly the same impact as for the women, but there's conflicting data on really what happens to the ovary with long-term testosterone use, both in animal and human data. We know in hyperandrogenic states, we do get PCO type architecture within the ovary. And we actually give testosterone, and in some cases DHEA, which is a milder androgen, to patients to get them pregnant. So we use it in IVF. There's some small RCTs to suggest you may get increased follicular recruitment and increased egg yield in IVF. The endometrium pretty much dries up, becomes atrophic in these patients. Part of the reason we get the amenorrhea, and that's a direct effect and related to the estrogenic effect of the androgens. And we do see pregnancies. There's small case series in trans men, and in hyperandrogenic states, you can get pregnancies as well. So for the women, the goal, of course, is to feminize, and that's through a combination of estrogen and anti-estrogens. And we want to limit hair growth. We want to reduce lean muscle mass. We want fat distribution in a more feminine distribution, and breast development, of course. And it takes longer to get there, 6 to 18 months. And again, we get a maximal effect in beyond 2 years. The voice change is the challenge. Once puberty is hit, it's very difficult to increase the frequency, the pitch of the voice. So that's a more long-term effect from puberty. The risks are greater in the women. Breast cancer has been shown to be increased compared to cisgender men. This can be seems to be related to progesterone use. Thromboembolism appears to be higher compared to all cisgender people, and that can be mitigated to a certain extent by adjusting the dose and using patch. The birth control pill was widely used in Europe previously. It's not used anymore. Ethinyl estradiol is what's linked to clots, so you won't see that in any of the protocols. And cardiovascular risk is there, and it seems to be higher compared to HRT patients that are postmenopausal. So more risk with these patients. Again, this is Transcare BC's summary, a great one. The androgen blockers were mostly using the antagonists, spironolactone, a diuretic, of course, an antagonist at the androgen receptor, and cyperterin acetate commonly used as well as for its progesterone effects. Finasteride is a 5-alpha reductase inhibitor that works mostly at the follicle, so dealing with alopecia and hair growth. Estrogens are used in a variety of forms. Patches seem to be most common, and progesterone is used for its anti-androgen effects within the brain, so it suppresses LH secretion in the brain. And again, this is more for your reference, just to give you kind of the timelines we get with hormone effects. So for fertility effects in the transgender female, obviously we're most concerned about the effect on sperm production. Variable with the protocols and duration of use, and you can get low sperm numbers or complete azoospermia, and even overt testicular atrophy and maturation arrest. And of course, this is assessed through a semen analysis. The effect seems to be reversible based on small case series, but a small percentage won't recover. And we see that in our general fertility practices with guys that misuse testosterone for bodybuilding. Recovery of sperm is based mostly on actually male hormone contraception studies, and this was a big meta-analysis published in Lancet with 20 million as defined as recovery, and these guys had a range of 16 to 78 weeks of use, and you can see the percent that recovered with time, but 3 to 4 months is generally what we set as the time for recovery, but some take up over a year, certainly. So these patients present with a huge number of permutations depending on their needs and their partner, of course. So you can create a grid that's just massive in terms of the different treatment pathways to be used, but our group had developed this in a review we're writing to kind of break it down into its components. First would be to decide when they want to get pregnant, which is true of many of our patients. If they're wanting to preserve their fertility and try in future, then we have the option of banking through the different cryo technologies. There's egg, embryo, sperm, and ovarian tissue. Freezing, and then for those that want to get pregnant right away, to break it down into patients with ovaries, uterus, and sperm. So egg freezing is used, as you know, widely for single women, typically presenting in their mid-30s, to freeze eggs to delay childbearing, and in our cancer patients pre-sterilizing treatments. Does require ovarian stimulation, so you have to put the patient through an IVF cycle. Don't need sperm. Overall, we believe the pregnancy rates are lower relative to embryo freezing. So that's always encouraged if that's a possibility. Relatively few babies compared to our other technologies, and most of them are from frozen eggs coming from the US egg banks. Very few women in general are coming back yet to use their eggs if they're freezing them for delayed childbearing. And for the trans men, it's just expert opinion that would tell us to pause the testosterone therapy. And there's really no data. Sometimes it's based on the physiology, which would be about 3 months. If you go by return of menses, that's about 3 to 6 months. So that can be quite a long period of time. And these guys don't want to stop testosterone. You're not going to find many that are big on that. Do get similar egg yields relative to cisgender women. So the egg yields seem to be good. So our group published a case report that challenged the premise that we need to stop testosterone. This was a 28-year-old transgender man, had been on testosterone for 3 years, was scheduled to undergo gender affirming surgery, THBSO. AMH was 13.5, which is normal, in the low normal range, and absolutely did not want to stop testosterone for any length of time. So we had him stop at 1 week prior to IVF and then start immediately after egg retrieval. We used a fairly standard protocol, a junior antagonist protocol with, because we often just have one shot at this, the highest dose of FSH we would normally use. Managed to get 13 eggs, 11 mature that were frozen. So this challenged the premise that we even need to stop. And this is a cartoon of what we would see in a cycle like that, not unlike what we'd use for a cancer patient, except that we have testosterone on either side of the cycle. We use letrozole in pretty much all of our cancer patients at the highest dose to suppress estrogen production during the cycle. We don't need estrogen to get eggs. It's just a byproduct of what we do. It just drives the lining to get thicker, but we're not getting pregnant, so we don't need it. But for the trans men, they don't want estrogen, so it makes sense to suppress it. And then the question becomes how many eggs to recover. And there are some models that are used in the single cisgender patients to get a sense of how many cycles to go through, to a certain extent, what dose of medication to use. But you can see, of course, the older you are, the more eggs you need to achieve the benchmark, which is generally set at a 75% chance of having at least one baby. And this graph is taking data from IVF cycles. So embryo freezing is very widely used. Of course, requires ovarian stimulation. We need eggs, and we're fertilizing those eggs immediately, so we need sperm. That may be partner sperm, it may be donor sperm, but need sperm. Easily the most established fertility preservation technique for our cancer patients. Live birth rates seem to be better compared to egg when you look at indirect national data. And the difference in pregnancy rate can potentially range between 5 and 10%. Of course, with fertilizing an egg, you don't have the reproductive independence. Both parties would own that embryo. And there's millions of babies born, and we have great national data. You may not have clinic specific data. It's reported nationally anonymously in Canada. But each year, our national society, CFAS, does publish the data for Canada to get a sense of what age effects would give you a specific pregnancy rate with those embryos. Ovarian tissue freezing and transplantation is, even though the experimental label has been lifted, many of us do consider it still somewhat experimental. We don't require ovarian stimulation. We're taking tissue out. Often it's being taken out when we're there anyways, when surgery is being performed. Would be the only option in the prepubertal patient where we can't stimulate the ovary. It does require surgery, typically laparoscopy. Worldwide, there's probably not even 200. It's a bit mixed. The last number I saw was in the 160s. And this is after over 2 decades of use of this technology. So many of us would not consider it really a viable option. A lot of the pregnancies are from natural conception with the native ovary still in the patient. So the question is sometimes whether they even got pregnant from the graft. So for the trans women, we're really just need sperm. So similar to the cancer patients, we simply just get, in most cases, a sample from masturbation. So an ejaculated sample is the most common approach. In cases where we can't get a collection for whatever reason, then testicular sperm is sometimes used and can be used in future for IVF. And for the cancer patients, the blanket recommendation from ASCO, the American Society for the Oncologists, is 3 samples, but that's somewhat arbitrary. Often, many cases, we can just get 1 or 2 depending on the situation. So for getting pregnant, there's even greater number of permutations. It's really, there's no restriction from either Health Canada or the college or in practice in terms of what you can do. Every technology is available for these patients. It's just a matter of what they want. They're very educated patients. They educate us. They definitely educate me. They often come in with a plan of what they want. They know the technologies, and and it's a matter of working through what's feasible and what pregnancy rate we can get with each. But there's no restrictions in terms of the new regulations from Health Canada in terms of what they do, because they're also often sexual partners, so there's no limitation legally. But with ovaries, the one thing to hone in on here is IVF, and sometimes the embryo is going back in them or to the partner, and that's reciprocal IVF as it's coined, and you'll see that in our consults sometime. But the rest are very much similar to what we have. And for patients with a uterus, of course, we can't use testosterone in those pregnancies because it's teratogenic. So quickly, the take-home message here: as healthcare workers, I think we do need to familiarize ourselves with at least the terminology and the issues in these patients. And this is a great website, EGAL, which has a great review of the terminology. Growing number of Canadians are presenting with transgender reproductive needs, and at least 50% of them are going to be using hormone treatments. So the fertility issues need to be addressed. And fertility preservation is definitely underutilized, fewer than 10% of the patients. Testosterone therapy for the trans men may have limited long-term impacts, but a small percentage of them will be affected. And for trans women, recovery of sperm production on average 3 to 4 months after stopping estrogen. And egg and embryo freezing is a great option, and appears that we don't need to stop testosterone, which is a huge breakthrough for these patients. Ovarian tissue freezing, as I mentioned, somewhat experimental and not widely available in Canada. We do have the option here at PCRM, so we do have the technology here, but very rarely used. And sperm freezing for the trans women. And as I mentioned, all medical fertility treatments are available for these patients. So this is a list of some resources for you, and you'll find others online, but these are the big ones in terms of international, and Transcare BC does a fantastic job, and EGAL. Any questions, guys?
I have a couple questions here. The first one: how often are patients offered pubertal inhibition, and how can we counsel adolescent transgender patients regarding fertility?
I actually don't know the percentage that get that. Obviously, there can be panic in once they've developed the dysphoria. It can be somewhat of an emergency to get to arrest puberty, but that would obviously start often with changes occurring. I don't know the percentage, honestly. The pediatric aspect I'm not exposed to, but I do counsel these patients, so I do definitely see adolescents. They're not ready often not ready for the fertility discussion in my experience, but yes, they are on long-term suppression. And then the implications there is once they're ready to go through the hormone therapies, that they would consider some level of fertility preservation. But often the discussion's coming through the parents. But I have engaged a few of these kids, and it's actually for me the most having kids in that age bracket the most fascinating part of this. But yeah, they're troubled, but the percentage I'm not sure.
And we have someone who'd like to ask a question verbally. Caroline, I'm going to allow you to talk if you would like to unmute. Give her a quick second here. Maybe not. Okay, then I'll just do one more written question. Does the length of time a transgender patient is on their hormone treatments affect their fertility if they decide to pursue fertility treatment years after they have medically transitioned?
Well, that would be mostly for the trans women. So the longer the higher the dose of the androgen therapy and the longer the time duration, the less likely you're going to get recovery. But as I said, it's mostly case series. We don't have a percentage. It appears to be low, just requires time. So obviously the implications there is they're off therapy and suffering with that loss of